So let's discuss occupational disorders. So first, these cases are rarely seen. Like you won't ever diagnose an occupational disorder unless you are a respiratory medicine, like pulmonologist. So and this, so don't focus much on this. There's no concept here. Just mug up. Just no basic information because they are very rare cases. Okay, so occupational disorders include pneumoconiosis, hypersensitive pneumonitis, and occupational asthma. So we will discuss pneumoconiosis here. So pneumoconiosis is defined as accumulation of dust in lung and the response of the lung tissue to this dust. Types of pneumoconiosis are silicosis, cold-worker pneumoconiosis, and asbestosis. Out of these three, silicosis is most common. Anyhow, this is very rare, so don't focus too much. So silicosis is due to silica dust from quarries, rock, granite, and ceramic industries. So what happens in silicosis is that the silica dust attacks the pulmonary macrophages and kills them. So due to this, two things happen. First, the chances of lung infection are increased due to low pulmonary macrophage counts, and some of those pulmonary macrophages may have TB, tubercular bacilli in them, because in this low mine workers, low socioeconomic status, TB is really common in India and mostly in the low socioeconomic status. So these patients may already have TB bacilli in their macrophages after phagocytosis, and as the silica dust kills the macrophages, the TB bacilli are free and they get reactivated. So silicosis mostly present as silicotuberculosis. That silicosis damaged by silica dust and TB is altogether. So presentation can be acute or chronic. So acute is exposure 1 to 2 year. In this, mainly the patient presents as silicotuberculosis. Presentation will be severe dyspnea, weight loss and cough due to TB, and hypoxemia due to the inflammation and the consolidation going on. Then in chronic silicosis, there is chronic dry cough and progressive dyspnea. On chest X-ray, there is no pleural involvement, and bilateral lung opacities are seen due to consolidation. Cavities may be present or not, as TB may be present or not. So the lung opacities will be as nodules, okay, because there is no pleural involvement. So the nodules due to consolidation in acute stage are mostly 2 to 3, and in chronic the multiple nodules together join to form a conglomerate or large nodule, and these are bilateral nodules. It is in both lungs. And in chronic hilar lymphadenopathy is also seen, which is seen as eggshell calcification, that the lymph nodes at the hilum area are calcified, they appear white, and there is a white margin around them, like there is an egg at the hilum. On HRCT, these findings can be confirmed. On spirometry, we will see mixed pattern: obstructive because of the consolidation, and restrictive because of the fibrosis in chronic stage, like the PAM are decreased due to the silica killing them. There are repetitive infections of lung, which led to repetitive parenchymal damage and leads to massive pulmonary fibrosis. Massive pulmonary fibrosis, which leads to ILD. So there is mixed pattern: consolidation due to acute infection by decreased PAM count, which is obstructive, and ILD is restrictive. So there is spirometry mixed pattern. So there is no treatment for this, just symptomatic management. Then there is cold worker pneumoconiosis. So this is furthermore even rare than the silicosis, but just still know few points for exam and for a basic introduction. So it is also known as black lung. Okay, this is a short question type thing. Then this is seen in coal miners. Pathogenesis same as silicosis. Here the coal dust is doing the same thing. On chest X-ray, there's again no pleural involvement, but here nodules are large. Again, cavitation may be present or not, because this will be also associated with TB. But here is no hilar lymphadenopathy here. That is no eggshell calcification kind of thing. Other than that, everything is same. Now comes to asbestosis. So this is furthermore rarer than both the previous one, but just not because of the cement entries, because of type of industries. And for just like somewhat introduction, so it is mostly seen in cement, shipyard, and textile industries workers. So what happens here is it is different than the previous two. Here what happens is only pleura is involved mostly. So pleural thickening will be there, which will be due to calcification of the pleura. Then on presentation there will be minimal cough because there is no consolidation, no bacteria inside the alveoli which the lung will try to cough out. So the cough will be minimum, but dyspnea will be there. On chest X-ray, opacification will be there, but they will be due to pleural plaques, that is pleural thickening by calcification, not due to some consolidation. There will be no hilar nephropathy because there is no infection as such. Then on HRCT, so HRCT will, like, we cannot differentiate the opacities of the pleural plaques and opacities of nodules on CXR. It may be hard for you. So HRCT will do this, because on HRCT, like, this is our lung field, this is vertebra, this is our lung field. So the nodules will be seen in the parenchyma according to the area, but the plaques will be seen in the pleura. So it will be easy to differentiate. Spirometry is restrictive pattern because there is no consolidation, so no obstructive pattern. Treatment is symptomatic.